I may be going to be more like a devil's advocate over here about should all fields go towards targeting a single pathway with just targeted therapy. And I'm here to talk about lessons we've learned from the trials we've done in a devastating disease that we see in our patients called Idiopathic Pulmonary Fibrosis, or IPF, which shares quite a lot with rheumatology. IPF, it's a progressive lung disease. The lung progressively scars up. This is an airway, this is a blood vessel, and the lung just starts to scar up. The airways dilate, and basically you just get dead lung. And it's a disease that affects most of our older patients. There is some association with exposure history. We've seen around 70% of these patients have it in those that smoke cigarettes. There is those that work in occupations that are exposed to dust and fumes, and this tends to affect men more than women, and we're starting to see that this may be related to genes that regulate aging. And finally, this is quite a fatal disease with an average lifespan of only around 2 to 3 years. From the moment these patients are diagnosed, at the end of 3 years, most of these patients are either transplanted or they've passed away. This is just a histology slide of pulmonary fibrosis. I just wanted to show you that from our medical school days, we know that the alveolo-capillary membrane, or the surface in between air and blood, is supposed to be extremely thin, but in these patients, this is quite thick, and as a consequence, there is this impediment to air being effectively or effortlessly absorbed, and therefore these patients struggle to breathe. Histologically, and that's what's driven most of us towards looking at how we can try to look at drugs to modify this disease process. And we've seen primarily that there's a lot of scar that happens. We see something what we call old scar, or that is established scar that is more deeper into the lung, and at the edge that separates old scar from normal lung is an area of active young scar with these sort of fibroblastic foci that we call, that tend to drive almost like a fire going in towards normal lung. And we've always noticed that within these areas, there's almost always infiltration of lymphocytes and plasma cells. So we've always thought that this is some sort of an inflammatory lung disease. And the problem has been that we've seen this to happen in rheumatoid arthritis, wherein this pattern of lung disease is seen in rheumatoid arthritis, what we call the UIP pattern. We've seen it even in smoking-related lung diseases to do this. And so for the longest time, we thought this was lung inflammation as a consequence leading to scarring. So that's what this slide is about. We thought that this is a chronic inflammatory lung disease that's been triggered off by these various particles. We have evidence to say that the balance of the Th1, Th2 phenotype is switched towards more of a Th2 phenotype, and that's something we know well from even the days of treating patients with tuberculosis, because patients who smoke and get TB, because of the predominant Th2 phenotype, have less adequate granuloma formation and get disseminated disease. We've known that for years. And there's excess proliferation of fibroblasts, there's collagen deposition, and like I said, we've drawn this paradigm primarily from seeing our patients with rheumatoid arthritis and from smoking-related interstitial lung diseases. So what have we learned from these anti-inflammatory trials? And I've put over here lessons from failure. So this is just to show all the various pathways we've tried to target and block, which in the lab we've seen has been very successful in being modified to stop or even in some cases reverse fibrosis. And it just goes to show that there is indeed inflammation that is activated in pulmonary fibrosis. So the first thing that we looked at was, how about a combination of prednisone and cyclophosphamide? And this we've known prednisone cyclophosphamide is something we've given for patients with scleroderma lung disease, and it's shown benefit in it. And so we said, why don't we look at giving a combination of prednisone cyclophosphamide for these patients? And basically it showed it did not help at all. There was no change in progression-free survival. There was no change in pulmonary function, and obviously cyclophosphamide being a toxic drug, the quality of life was definitely worse. So we said, all right, then let's move on. So there was this little study that came out of Austria that says, yes, because of the Th1, Th2 flip, maybe we should just augment Th1 with giving these patients interferon gamma. And so we said, all right, let's do a trial looking at interferon gamma in patients with pulmonary fibrosis to try and remodify, get the balance back a little bit. And when we did that, again, we were unsuccessful because it showed no changes in outcomes. Patients progressed despite this disease. Their lung function kept declining, and this wasn't an easy drug for these patients to handle. So then we took it another step further. Maybe we should look at a less toxic drug like azathioprine, because what you got to remember is in the lab, when we look at mice models that we have of pulmonary fibrosis, these drugs work in reversing or even slowing down the fibrotic process. So we said, maybe we should look at azathioprine, and maybe we should add another line besides targeting inflammation. Maybe we should target because the lungs are constantly exposed to oxidant-mediated stress from the environment. We said maybe we should use some antioxidant combination here. So we gave them N-acetylcysteine as well, and as you can see, again over here, these patients actually didn't do well. And when you look at the graph over here, it found that when we gave these patients the combination immunosuppression, they had a higher rate of being hospitalized or a faster accelerated rate towards death when we gave them this combination. So not a good combination again. Then we said maybe we should do what rheumatology does. Let's just look at a single pathway, because in the lab we've seen, okay, blocking TNF-alpha, because TNF-alpha we've seen is extremely pro-fibrotic, and we've said maybe we should block this and see what's going to happen in the lungs. And so we did a trial looking at etanercept in IPF, and just like all our other trials, we found that this doesn't work either. And it's not been surprising, because in clinical practice, when we see patients with rheumatoid arthritis who come and see us for the presence of pulmonary fibrosis or fibrotic interstitial lung disease, we have always seen that giving them the TNF blockers, be it etanercept, be it infliximab, adalimumab, none of these have changed the trajectory of their fibrotic lung disease. So even though it may work for a disease that systemically has been shown to respond, we've seen that in the lungs, it does not respond, strangely enough. So we said maybe, okay, we still got to go down this path of targeted therapies. Maybe the reason why this didn't work is we need to use drugs that are even more difficult to pronounce. So we went towards another molecule that is really pro-fibrotic in the lungs. We blocked anti-IL-13. In the lungs, IL-13 is extremely pro-fibrotic. It has been shown to cause a lot of airway remodeling, especially in asthmatics. And so we said, let's look at this tralokinumab in pulmonary fibrosis, just blocking that. And again, it didn't do anything. So we were like, what is going on over here? So we said, okay, so we went back to the lab and we said, why are these, we see inflammation here, yet blocking inflammatory pathways is not successful. So the other part of the whole equation of these, of IPF has been, when we looked at our animal models of pulmonary fibrosis, one of the best known models that we have is bleomycin-induced lung fibrosis. But when we've broken it down and looked at bleomycin causing pulmonary fibrosis, bleomycin targets the lungs by injuring the endothelium. So we have the epithelium, which is the alveolar epithelium, and right below it is the pulmonary capillary endothelium. And bleomycin injures that, and because the two are so proximate to each other, there's injury to that entire complex. And we have seen changes in the lungs, which is every time the lungs get injured, we've seen the secondary phenomenon of a robust growth of blood vessels in the lungs. And that's something we've seen. And we see this exuberant growth of little blood vessels. And we've always thought that these, and VEGF levels, the vascular endothelial growth factor levels, are significantly higher in lung tissue that's been injured. And so we initially didn't know why, but then later on we felt, at least today we think that the reason why there's this angiogenesis is that as more and more capillary beds get destroyed, there is the need for this angiogenesis so as to offset the rise in pulmonary pressures. And so we get this exuberant reaction that we've seen. And so we said, okay, and we've seen endothelial injury because endothelin 1 is markedly expressed in patients who have pulmonary fibrosis. So we said, all right, let's target these drugs. So we said, maybe let's look at Coumadin or warfarin to interfere with the whole coagulation cascade and see if that's going to change outcomes in these patients. Again, it didn't work. And then we said, okay, maybe let's look at this whole angiogenic component. We said we can look at imatinib, which just targets anti-PDGF. And here again, I mean, in the lab, I was in the lab at Mayo when I helped Craig Daniels I helped him sacrifice the mice after we gave them, it's not a very proud job that I'm confessing here, but when we looked at these mice and gave them imatinib with pulmonary fibrosis, their lungs healed really nicely. But then when we came to the human trials, again, it did not work at all. So then we said maybe we should go after the vasculature themselves, and we gave these drugs that we use in pulmonary hypertension, bosentan, ambrisentan, macitentan, all these drugs, none of these drugs, again, worked. And then we said, let's try sildenafil. And this was, the one good thing about this drug was that even though it showed no change in slowing down the progression, no change in pulmonary function, the patients were really happy on this drug and quality of life scores were very, very high. So that's the only thing, the good thing that came out of this trial. I wonder why. So what have we learned here? I mean, we, as pulmonologists, we say, we've not failed. We've just found 10,000 ways that this doesn't work. So we had to go back to the whole drawing board and say, what is going on over here? And today we've realized that IPF is like this Greek mythological creature that we call Hydra. I don't know, I'm sure, I mean, I'll give you another example of Hydra, but Hydra was this Greek mythological creature, a sea monster that Hercules had a hard time killing. And the reason why was it had 9 heads, and every time Hercules cut off one head, 3 heads came, or 2 heads came in that place. So every time he tried to chop one head, several other heads came in the way. And that's what we think of as in a disease like IPF, because we're starting to see in IPF, there are redundant pathways, multiple pathways that are intertwined, and we see that there is a combination of injury, inflammation, and scar, but many pathways that crisscross across. You try to target one pathway, the others just take over the job and just continue the whole process. So this is for the younger people in the crowd, those that read Marvel comics. This is the Hydra that we know today. That's Red Skull. And this was the Hydra command. You cut off one head, 2 more shall take its place. Hail Hydra. All right? So there's been a complete paradigm shift for us in IPF. So we've today, in the way we design trials, the way we're looking at approaching targets in these patients, is no longer targeting one pathway, but to go after multiple pathways. And thus far, we've seen there's abnormalities in epithelial cells, so alveolar epithelial. There's clearly abnormalities in immune dysfunction. We know that without a doubt, but just blocking this alone has been insufficient, and there is excessive fibrosis. It's almost analogous to what the dermatologists see with a chronic open wound that is so hard to treat, or with keloids that they have such a struggle with treating because it's just exuberant scar, there's excessive angiogenesis, there's inflammatory cells, there's issues to deal with the microbiome, all of these things play, and it's just so many multiple things get involved that it just targeting one has been very hard for us to take care over here. So as you can see over here, we've seen epithelial cell dysfunction, and this is where the whole aging paradigm comes in. We've seen that this disease affects men more than women because men tend to lose the telomeres at a much faster rate than women. So for years we've known that men age faster and die faster than women, and now we know there's a genetic basis behind it. It's not because of Chad's last slide of the wife not feeding him or providing him with any joy. And then we've seen abnormalities of the immune system, and we've also seen there's excessive activation of the whole fibrogenic process over here. So we said, maybe we shouldn't go after one target. Maybe we should use drugs that hit multiple targets. So here comes a drug that we borrowed from the cancer world. It's called nintedanib, and this targets, it's a tyrosine kinase receptor inhibitor, and it blocks areas of angiogenesis, blocks areas of inflammation, and blocks areas of fibrosis. So when we saw that we have this one drug that targets these areas, although it's not equal, there's some degrees to it, we said, let's do a trial with this medicine. And lo and behold, we found that when we give this drug, finally, we found a drug that slows down disease progression. Around by 120 to 200 cc's per year, in these patients, they tend to lose around 200 to 400 cc's of their lung function per year. And now, and on average, you lose around, 60 to 100 cc's per year. So we've been able to slow this down, not reverse it, but at least it's been helpful in prolonging life in these patients. So, like I said, how does nintedanib work? This is a multi-receptor tyrosine kinase blocker. It blocks PDGFR, which imatinib only blocked, but on top of it, it blocks what VEGF, which is vascular endothelial growth factor, so the angiogenesis, and it also blocks fibrosis with fibroblast growth factor receptor. And so as a consequence of this, we've seen when we've hit multiple pathways in a process as complex as this, we've seen some benefits, at least slowing down disease progression here. And then we have another medicine that did get approved for pulmonary fibrosis, which is pirfenidone. It also reduced disease progression by around 200 ml per year. There was improved exercise tolerance, and now we have patients who have, and we were one of the earliest centers to study this drug. Even though it got approved in 2014, we have patients who've been on this drug since 2004, and we still see those patients today. So almost 10 years down the road, we're seeing patients with pulmonary fibrosis, which is, at least for us, we think it's pretty decent, especially for a disease when they die within 2 to 3 years. Now, how does pirfenidone work? The truth is, we don't know how pirfenidone works. The analogy we use is that it's almost like the methotrexate of pulmonology. We don't know how methotrexate works really, but it works. So same here, we don't know fully how this drug works, but it does have anti-inflammatory effects. And I put this up here because I think almost every disease is now becoming an auto-inflammatory disease, but we've seen significant abnormalities in the innate immune system in patients with pulmonary fibrosis. A lot of this comes from our genetic trials, where we've seen patients who have genetic abnormalities in their innate immune system are predisposed to fibrosis. And then it's got anti-fibrotic properties by being able to reduce TGF-beta. And we have looked at just, can we target TGF-beta alone? The problem is TGF-beta does good as well. And so when you do this, there's so much harm that just targeting TGF-beta alone has for us, and because of its antioxidant properties. So in conclusion, we've seen that at least in the lungs, the fibrogenic process is multifaceted, redundant, and these pathways are all intertwined. Obviously, we say if we can find the cause of fibrosis and eliminate it, the lungs have got a pretty good plasticity to heal, but our history tells us that targeting a single pathway has not been successful, just like rheumatology, dermatology has been, or even GI has been successful with targeting a single pathway. And so our path moving ahead has been to look at medicines or combination of drugs that hit multiple targets. And finally, the other thing that we're now looking at is, because there are so many players involved in this, we're trying to look at which of all the multiple players are upregulated or dysregulated, rather, causing this fibrogenic process, so we can target particularly those, like in precision medicine.